Hello, PsychU community, and welcome to today's webinar, Innovations in New Payment Models, a look at state examples of value-based payments. Very exciting topic, and obviously the shifting landscape of different payment models is certainly impactful across the entire mental health landscape and all of healthcare for that matter. So as we get into our discussion today, I have two of my esteemed colleagues with a tremendous amount of experience. So Deb and Steve, I'll post the first question to Deb. So what are some of the value-based payment models that you've seen being put into place?
Sure, Paul. When I think of value-based payments or alternative payment models, I really think of a continuum. Anywhere from pay for performance, where you basically get, a bonus payment or an escalator or additional funds because you've achieved a certain performance level. So it starts, from that level of the continuum all the way up to capitated payments. So I would say in the behavioral health area, because it's still relatively immature in terms of value-based payments, most of what you see happening is performance-based payments. If you hit the HEDIS measures, you receive a bonus. If you hit, a certain readmission rate, it's generally upside incentives. However, I have seen, and maybe we'll talk about it a little later, I've also seen bundled payments being used quite a bit in the behavioral health and substance use space, particularly substance use. And a bundled payment really allows you to take an array of services and wrap them together into a single payment or bundle or case rate. So those, I think, are the two most common that I see today in the behavioral health and substance use space.
Great, thanks, Deb. Steve, any perspective on what the kind of models you're seeing?
Yeah, I would echo what Deb said. I would also add to that, I'm seeing more and more requirements for integration of care being built into the plans. I'm from a state perspective. I come out of Pennsylvania, where we have value-based purchasing being developed in the state. Kind of at a middle level. They're not highly evolved, but they're moving along that continuum that Deb mentioned towards more bundled payments and even starting to think about some capitation. So we're seeing the beginnings of that, but really the integration, making sure that substance use needs are being identified and that outcomes are being tracked more closely. The integration with physical health is really one area that I'm seeing more and more push from states, and even I've seen a couple commercial contracts now, and they might have a number of different measures that they're using, and I'm seeing more and more of those measures being an integrated care measure.
Yeah. So in terms of your experience, Steve, with Pennsylvania and the other states that you've been working around, what kind of models are you seeing being developed relative to value-based payment?
Right. The models that we're seeing out of the gate for most states, and keep in mind, there are many states that are just starting to dip their toes into the water on this. And so they are, the struggle out of the gate is just to get their systems up to the point where they can gather data, report data, and use data for their quality improvement processes. So as that's developing, there is a high amount of financial and human resource infrastructure that needs to be aligned to those processes, and that can be a little bit expensive out of the gate. So many states start with the pay for performance because that incentive money can be reinvested into the infrastructure they need to move to the more complex levels of value-based processes.
Right. Deb, how about your perspective?
Yeah, Steve makes a good point that, moving to these more complex approaches like capitated payment are really pretty challenging at this point. We're still living in what I would call a PCP world, where with the PCPs you can certainly attribute members or assign individuals to that PCP. So capitation is easier in the medical world because in general, individuals aren't assigned to a behavioral health provider, right? So that attribution that would be required to do capitation is not as easy to do in behavioral health, unless it's a health home, right? A behavioral health home, you can move to more of a capitated arrangement. So I think Steve hit on a good point, that the reason pay for performance is used is you don't have to do a lot of system changes, right? You can pay a bonus, or you can escalate their payment if they achieve that performance. So you're not doing a lot of unique things with the system. Bonus payments, though, are tricky because you have to figure out how you're going to fund those, right? They're not coming out of the medical spend, and so that's why escalators are typically used. If you perform well, we'll raise your rates X percent, 6%, prorated, whatever it might be. So I think it's important to be aware of it. It's a little easier both on the payer and the provider to use these performance-based escalators.
Deb, any specific state examples that you could think about relative to some of the uses of value-based payment?
What I've seen states do a lot is, they'll select measures that are part of their request for proposals process, their RFP process. I would say there's still some lack of creativity there. The HEDIS 7-day ambulatory follow-up measure is the tried and true measure that's out there across the board. But you do see, as Steve mentioned, integration. Some more and more are incorporating what would be medical HEDIS measures, or medication adherence measures based on pharmacy data. So that's often where those measures that are a focus come from. The other thing I would add is quotas. I do think a lot of states are moving to the use of quotas in their performance-based approach. And what I mean by that is they've set markers that, by the end of 2020, at least 20% of our total medical spend is tied to performance-based or alternative contracts. And then by the following year, another 30%. So they're using this quota approach to really push the system to move more to value-based contracts. And that can be helpful in some ways, but I would say it doesn't always mean a big change in the behavioral health space, because many payers can accomplish those quotas if they only target the PCPs. So unless they are creating some sub-quotas that say, and 5% has to be behavioral. So that is definitely the trend I'm seeing in states, is this quota approach.
Yeah, definitely. Steve, any commentary around what Pennsylvania's done? I know they're slow walking into value-based payment, but kind of any background there?
Yeah, and actually, Deb outlined one of the steps, which is for the last 3 years, they started by just requiring 5% of any level of value base. The second year was 10%, the third year is 20%. They haven't put out what they're expecting moving forward, but that should be coming out soon. I would expect it to be up around 40 to 50% moving forward. The interesting twist with that is that they say, in 2020, 20% of your services need to be value-based, but then they also specify that 50% of that 20% be at a higher level. So it needs to be a bundled payment or a capitation. So they're pushing the overall value-based, but they're also pushing the complexity, kind of trailing it behind, but expecting ongoing ramp up in that area as well.